Good evening, everyone that's on. We're going to start presenting here in just a minute. If you want these slides that Venetia is presenting, I need your email address and you can send that via the chat, and I will make sure to get those out to you by the end of this Zoom meeting. So Venetia, if you want to go ahead and get started, it's like 6:59, so we're good.
Sounds good to me. Hey, everybody. I had sent a message out earlier this week, just talking about this presentation being a large bulk of the test according to the outline. I think it said there were going to be 56 to 58 questions just on the concepts of renal disease. So I tried to be a little more descript in the slide presentation. So that you could, if you wanted to get a copy of it, you can make your own note cards or, whatever else you needed to make for study guide. But I'll just get started here. And I figured out how to upload and share, so it'll be hopefully a little smoother. But all right, starting with the concepts of renal disease. Next slide here is just the basic kidney anatomy. As far as the anatomy goes, the kidneys are retroperitoneal below the rib cage, kind of hiding behind the T12L3, roughly the size of a fist. The right kidney is slightly lower than the left. I think the liver has something to do with that. In a normal adult, gives the length, the width, the thickness, and then each kidney weighs approximately a half pound, and they contain up to 1 million nephrons each. The parenchyma, outer cortex, inner medulla. The cortex is this the red-brown portion that receives 90% of the blood flow. It contains the glomeruli, the tubules, proximal and distal tubules, the collecting tubules, peritubular capillaries. The medulla is there, and it contains the triangular wedges called the pyramids, formed by the long loops of Henle, and it contains the collecting duct and the collecting tubules, and the vasa recta. Let's see here. The medulla does play a crucial role in regulating water and salt balance. The pyramids are the triangular wedges. The papilla, tapered end of the pyramid where the urine is passed into the minor and major calyxes. The urine composition is unchanged once it passes through the papilla. The renal columns are the cortical tissues located between the pyramids. Also contain the loop of Henle, the medullary collecting ducts, and the vasa recta, as it said in the previous one. But the medulla is, I think, the most important takeaway, regulating salt and water balance. The nephron, two components broken down to vascular and tubular. The vascular is the afferent arterial glomerulus, efferent arterial, peritubular capillary network, the juxtamedullary nephrons, and again, this vasa recta. The tubular portion is Bowman's capsule, the proximal tubules, and the descending and ascending limbs of the loop of Henle, distal tubule, cortical collecting ducts, and medullary collecting ducts. Kind of a not too bad of a picture to put it all together with. Renal blood flow considerations. Nephrons contain highly metabolic cells sensitive to reduced oxygen flow, oxygen and blood flow. Complex neurohormonal reflex preserve and maintain renal blood flow. Renal blood flow starts with one artery branching from the aorta for each kidney, with multiple steps before the blood is returned to the renal vein, joining to the inferior vena cava. Nephrons, the glomerulus, we all remember learning that it is considered the filtering unit. Has tiny blood vessels attached to a tubule. The first step is glomerular filtration. First step in urine production, I should say. Then tubular reabsorption, where the fluid and solutes move from the tubular system into the peritubular capillaries. Then tubular secretion, movement of the solutes from the peritubular capillaries into the tubular system, and then excretion, passage of urine. Nephron types, cortical and juxtamedullary. So 85% are cortical. These are shorter and do not extend into the medulla, and they are regulatory and excretory functions. The juxtamedullary is only 15% and does have the loop of Henle that extends into the medulla, allowing for concentration of urine. The glomerulus, blood enters by the afferent arteriole and exit to the efferent through the efferent. Glomerular capillaries are 100 to 500 times more permeable than other capillaries. Filters fluid and small molecules, and they have 3 negatively charged layers: the endothelial, the basement membrane, and the epithelial. Bowman's capsule surrounds the glomerulus, has 2 layers. This is the Bowman's capsule. It has the visceral layer and the parietal layer. The visceral has the podocytes. And then there's Bowman's space, is the area between the 2 layers where filtered fluid and solutes are collected and passing to the proximal tubule. About 20% of plasma passes through the glomerulus into this space, known as glomerular filtrate. The proximal tubule starts right there, where the majority of reabsorption and secretion. The loop of Henle, absorption of solutes, primarily sodium and chloride. There's the thin descending limb that's permeable to water, and the thick ascending limb that is impermeable to water. The distal tubule is right there. It's the initial section contains right here, the macula densa cells, which is part of the juxtaglomerular apparatus. And the 2 sections, there's the distal convoluted segment, which is the part that is essentially impermeable to water for solute transport, and then the late segment for the regulation of calcium, sodium, bicarb, potassium. It is permeable to water under the influence of the antidiuretic hormone. And the distal convoluted tubule is the fine tuning of the filtrate composition. The collecting tubules, formed by several distal tubules composed of 3 segments: cortical collecting, medullary, and intermedullary collecting. The permeability of water is dependent on antidiuretic hormone. Without ADH, minimal water absorption, and the urine is dilute. And with antidiuretic hormone, water absorption occurs and the urine becomes concentrated. The juxtaglomerular apparatus has communication between the macula densa cells and the afferent arteriole. And that's important for maintaining systemic blood pressure. It kind of alerts to a change and can alter that filtration. The juxtaglomerular apparatus provides rapid communication between the filtrate within tubules and the blood flow entering the glomerulus. They're highly sensitive to sodium chloride concentration and flow rate of the filtrate. When the filtrate flow or the sodium chloride concentration decreases, These cells signal the afferent, arterial, and juxtaglomerular cells. These, I'm just going to call them the JG cells, contain secretory granules. Oh, sorry. Thought I had that on silent. Is filled with renin. Let me start that over. The JG cells contain secretory granules filled with renin, which is crucial for the renin-angiotensin-aldosterone system, which we will talk about later. Renal hemodynamics. So there's intrinsic factors and extrinsic factors. Usually I can speak, but maybe this makes me a little nervous. Sorry if I'm tripping over words here. The intrinsic factors is the kidney has autoregulation, the renin-angiotensin mechanism, synthesis of the icanosoids, and the icanosoids are phospholipids that play a role in the immune response. And some examples of these icosanoids are the prostaglandins, leukotrienes, and thromboxanes. And then there's synthesis of the kallikrein-kinin system, which is, I had to look these up, obviously. The kallikrein, I'm sure I'm saying it wrong, kinin system, when activated, releases proteins, enzymes, and peptides that help regulate blood pressure. They're involved in the inflammatory response. They interact with the blood clotting system and can stimulate pain receptors. So pretty important there. The extrinsic factors would be the sympathetic nervous system, angiotensin II, antidiuretic hormone, endothelins, nitric oxide, atrial natriuretic peptide, and dopamine. Normal kidney function. Every 24 hours, the kidneys filter about 200 quarts of fluid. About 2 quarts are removed from the body in the form of urine, and 198 quarts, or 180 to 187 liters, are recovered. Excreted urine is stored in the bladder until voided, and normal bladder capacity in an adult is 300 to 500 mLs. The kidneys receive 120 pints of blood per hour, 1,200 mLs per minute renal blood flow, and then every 24 hours, the kidneys clean 400 times the total blood volume, and 20 to 25% of cardiac output goes to the kidneys. So from the core curriculum, here is the definition of GFR. It's volume of plasma filtered from the glomerular capillaries into Bowman's capsule each minute, expressed in mils per minute. And clearance is a volume of plasma that is cleared of a specific solute by the kidneys per unit of time and expressed in mils per minute. And they are dependent on several factors. So the kidneys, some of their functions are the maintenance of internal homeostasis, the removal of waste products through production and excretion of urine, fluid balance and removal of extra fluid, electrolytes and minerals, acid-base balance, elimination of drugs from the body. Hormone production, so blood pressure regulation with renin, activation of vitamin D, help control red blood cell production, production of the urodilatin, possible generation of thrombopoietin, parathyroid metabolism, parathyroid hormone metabolism, prostaglandin metabolism, the primary site for insulin metabolism, and glucose creation, production in starvation states. CKD is considered the under-recognized public health crisis. In 2021, it was the 10th leading cause of death. Causes more deaths than breast cancer or prostate cancer. And current estimates are 1 in 3 American adults are at risk for CKD, which is about 80 million. 35.5 million Americans have CKD, which is 1 in 7. Approximately 90% of those with CKD don't know they have CKD. And for advanced CKD, 1 in 3 don't know they have CKD. Morbidity and mortality with CKD, the incidence of premature death is higher in those with CKD compared to those without CKD, regardless of the stage. Those with CKD are more likely to die prematurely, which is 5 to 10 more times, than to progress to ESRD, which is surprising. CKD definition per KDIGO is there's abnormalities of kidney structure or function that's present for 3 or more months with implications for health. CKD classification, I've seen this multiple places. I really do like this classification and staging. It's based on cause, EGFR category, and albuminuria category. I did an educational, was talking about someone with CKD stage 3A, but if they have proteinuria greater than 300, their risk is so high to progress. So they're just a very high risk to progress to ESRD. So controlling that albuminuria is obviously can't be understated here. So the spot urine to albumin to creatinine ratio, ACR, importance for evaluating for proteinuria cannot be emphasized enough. Established marker for CKD. Albumin is a type of protein normally found in the urine in small amounts. Albuminuria finding in patients with CKD, it's an earliest indicator of glomerular diseases, and it can be present before there is a decrease in glomerular filtration rate or even an elevated creatinine. The total protein excretion rate or albumin creatinine ratio can be measured in a 24-hour urine. A urine albumin creatinine ratio of greater than 30 milligrams per deciliter corresponds to a urine albumin excretion rate of 30. Importance of instructing the patients on the proper collecting technique. Improper collection will negatively impact the validity of the test. And then going back, so 30, less than 30 is considered normal, 30 to 300 is moderate, and then greater than 300 is the severe category. Oh, sorry, it was right here. And so albuminary proteinuria. So the elevated risks, more rapid progression to CKD, renal failure, higher risk for cardiovascular events, regardless of diabetes, and just a higher risk for death in general. Concerns for urine spot testing for albumin should be avoided when the patient has exercised strenuously within 24 hours of testing, they have a UTI or a fever, or a female that's menstruating. GFR is considered the best overall index of kidney failure and the ability of the kidneys to filter blood. Normal GFR varies according to age, gender, and body type, and declines with age. There's a new formula, 2021, called the CKD-BPI creatinine, provides an estimate of kidney function that takes into account the age, gender, and serum creatinine. Per KDIGO, use of any GFR equation is acceptable, as laboratories may still be using the older formula, and there is a suggestion that knowing which laboratory or which formula your laboratory is using. For pediatric consideration, there is a bedside Schwartz formula for ages 1 through 17, and it utilizes serum creatinine and height. And then also cystatin C formulas are also available and can be utilized for pediatric considerations as well. And cystatin C is a cysteine protease inhibitor. And then when kidneys are functioning normal, the cystatin C is kept within normal limits. An increase in levels of serum cystatin C can indicate a worsening of kidney filtration. And it's helpful if somebody believes that the GFR may be inaccurate and anything else has been inconclusive. Testing for the elderly, if there is a person with a lot of muscle mass, for obesity, or someone with extreme diets. It's considered more accurate measurement of kidney function as it's less influenced by gender, age, and muscle mass than creatinine is. It's more expensive than a serum than for serum creatinine and may not be readily available in all labs. Previous concerns regarding serum creatinine's national standardization versus the statin C assay testing variation standardization. This was in the other slide. I wasn't quite sure how important that was, but I did add it since it was included in the last slide. So keep that in mind. And the only thing I found was the glucocorticoids may increase the cystatin C level. I have seen the cystatin C used a lot more for just to confirm kidney function, and definitely the elderly and people that work out. eGFR, age and gender considerations. For young males, 130 is normal, 120 for young females. And normal loss of eGFR due to age starts in ages 30 to 40s with a loss of eGFR at 0.75 mLs per minute per year to up to 0.96. Progression of CKD, slight fluctuations in eGFR are common. A decline from the baseline of 25% is cause for concern. Rapid progression of CKD shows persistent decrease in GFR greater than 5 mLs per minute per year. And these are our GFR categories. Less than 15, 15 is kidney failure, 15 to 30 decreased, and then 3 has been divided into 2, 30 to 44, 45 to 59, and then stage 2, 60 to 89, and then greater than 90. The limitations: extreme muscle mass, very frail, or bodybuilders, amputees, paraplegics, unstable creatinine, such as with acute kidney injury, pregnancy, unusual diets. So if someone's on a very high protein or meat diet, falsely elevated serum creatinine, a strict vegan can lead to false low serum creatinine, and that's where the cystatin C would be the better choice. CKD versus AKI. Acute kidney injury is a sudden decrease of the kidney function or elevation of creatinine by 0.3 to 0.5 or more. Can often be treated and reversed. Common causes are injury, illness, or toxin exposure. Where CKD is a reduced kidney function for at least 3 months, there's 5 stages, can lead to kidney failure and need for dialysis or transplant. Criteria: any one of these must be present for greater than 3 months, and it's just one or more of the following: albuminuria, urine sediment abnormalities, which would be casts, epithelial cells, or red blood cells, electrolyte or other abnormalities due to a tubular disorder, abnormalities detected by histology, structural abnormalities detected by imaging, history of kidney transplant, or an eGFR of less than 60. Risk factors: age 60 or older, diabetes, hypertension, prior damage to the kidneys, such as an AKI, family history of kidney failure, obesity, heart disease, or premature birth, which I did not know that. CKD is slightly more common in women than in men. Of course, diabetes is the number one cause, hypertension number two. And these are populations that have higher rates of diabetes and or hypertension. African Americans, Asians, Pacific Islanders, Native Americans, and Hispanics. Common causes for CKD, ESRD. The third is, of course, first was diabetes, two, hypertension. The third was glomerulonephritis, is a disease that damages the kidney's filtering units. Inherited diseases, autosomal PKD, congenital malformations, immune diseases such as lupus, obstruction, such as prostate enlargement and kidney stone, and chronic urinary tract infections. Classifications, you have vascular, which is the renal artery stenosis, hypertension, vasculitis, and ischemia. Glomerular, which is diabetes, lupus, hepatitis, HIV, and medications. Tubulointerstitial, which be also medications, toxins, urinary tract infections. Cystic is polycystic and medullary cystic. Congenital is Fabry's disease, Alport syndrome, and vesicoureteral reflux. So vascular causes of CKD, renal artery stenosis is the narrowing of one or both renal arteries by 50% or more. Decrease in blood flow triggers the renin-angiotensin-aldosterone system. Initial symptoms can include difficult to control hypertension requiring 3 or more antihypertensives with decreasing kidney function. And 90% of the cases of renal artery stenosis are due to atherosclerosis. Risk factors, high blood pressure, smoking, diabetes, high cholesterol levels, and limited physical activity. Renal artery stenosis is a conservative management, smoking cessation, increased physical activity, dietary changes, lifestyle changes. Medications would be cholesterol lowering agents, diuretics, antihypertensives, and they can do surgical intervention by angioplasty or stenting of the sclerosed vessels. Hypertension, nephrosclerosis, second most common cause of renal failure for hypertension is primary versus secondary hypertension, risk for cardiovascular diseases, various guidelines available regarding blood pressure control. You have like various guidelines, I guess it'd be like the guidelines for renal, guidelines for cardio, and then multiple pharmacological options. And we often see patients on more than just one antihypertensive. Glomerular or glomerulonephritis is an inflammation of the glomerulus. Includes several diseases caused by different etiologies with differing signs and symptoms and outcomes. And it can be primary or systemic. Nephritic syndrome is hematuria from glomerular bleeding, misshapen red blood cells seen in the urine. Urinary protein can be present, and pus and cellular or granular casts can be seen in the urine. With nephrotic syndrome, may be the result of primary glomerular disease or due to a systemic disease. And with that one, you see edema, proteinuria, hypoproteinemia, and hyperlipidemia. Hypercoagulability may be present if albumin is below 3. You can have acute glomerulonephritis, which is the sudden onset of nephritic and or nephrotic syndrome. Kidney damage is often reversible with early detection and intervention. The goal is to stop the inflammatory process and block the immune response. Chronic progresses slowly, generally over years, typically asymptomatic. Nephrotic syndrome is common and can occur in almost all glomerular diseases. Protection of kidney structure and function is paramount. CKD and diabetes mellitus, leading cause for renal failure requiring dialysis in the US. Renal microvascular complications of the disease, important of monitoring EGFR and creatinine or albumin creatinine ratio. Proteinuria is not uncommon. There's an individualized glycemic control, and the common goal is less than 7, that is age dependent. Consideration for use of newer diabetic agents, blood pressure at goal, and consideration for use as ACEs, ARBs, especially if there is protein in A1 or 2 categories. And then it's now called diabetic kidney disease. Diabetic nephropathy is considered an outdated term. Tubulointerstitial diseases refers to diseases outside of the glomerulus. And then there's acute interstitial nephritis and chronic tubulointerstitial nephritis. Acute interstitial nephritis, or AIN, is a sudden deterioration in kidney function caused by infections, specific autoimmune disorders, can be secondary to medications, and there are 70 to 75 cases of this thought to be drug-induced, percent of cases thought to be drug-induced, as there is a large list, greater than 150 medications that are associated with AIN. Chronic is the clinical slower courses, can be due to a primary disease, systemic illness, glomerular injury, metabolic disorders such as hypercalcemia, hypokalemia, therapeutic and environmental agents such as lead, and medications that can cause AIN or chronic tubulointerstitial nephritis is the NSAIDs, lithium, cyclosporin, and cisplatin. Cystic diseases are the formation of cysts in the kidneys, and also, I think that was supposed to be systematically. I don't think that's correct. I think it was, it can be in other organs as well than the kidneys, like in the liver. There's numerous types, can be acquired or inherited. Autosomal dominant PKD is the most common inherited renal cystic diseases, with a prevalence of 1 to 500 or 1 in 1,000. Formation of cysts in the kidneys and other organs. Cysts diffuse and cause significant enlargement of kidneys. Congenital occurs in 3 to 7 in 1,000 births and can occur anywhere in the renal system. Cause of majority of childhood CKD up to 70%. Major cause of morbidity in children. Cause of majority of pediatric renal failure cases can include unilateral renal agenesis, bilateral renal agenesis, or renal malformations. Considerations for CKD. As CKD worsens, the increased risk for developing anemia, metabolic acidosis, mineral and bone disorder, hypertension, electrolyte and mineral imbalances, nerve damage, poor nutritional status, damage to blood vessels, heart disease, kidney failure. So these next slides were taken from was a 2025 CNN study guide. It went into a little more detail about acute kidney injury. They described it as the sudden, abrupt, and often reversible decline in kidney function that occurs over hours to days, leading to rapid accumulation of nitrogenous waste products and disruption in fluid, electrolyte, and acid-base balance. Pre-renal is most common, which is caused by when there's an inadequate perfusion leading to impairment of glomerular filtration. So volume depletion, hemorrhage, burns, decreased cardiac output, systemic vasodilatation from sepsis, anaphylaxis, severe liver disease, renal artery stenosis, NSAID and ACEs and ARBs due to a constriction of the afferent arteriole and reducing glomerular filtration pressure. There's intrarenal AKI. So pre-renal, intrarenal. Intrarenal is let me go back to that. So this pre-renal is obviously something that happened unrelated to the kidneys. Intrarenal, something happened to the kidney structure themselves, affects the glomeruli, renal tubules, or interstitial tubules from acute tubular necrosis, which is the most common. And that was from prolonged ischemia from pre-renal. So pre-renal leading to intrarenal. Nephrotoxic agents causing direct toxicity to the tubular cells. So those were aminoglycosides, radiocontrast dyes, certain chemotherapeutic agents, heavy metals, some illicit drugs. These toxins accumulate in and damage the tubular cells. Acute interstitial nephritis is usually caused by an allergic reaction to meds, but can be caused by infections or autoimmune diseases. And acute glomerular nephritis is an inflammatory condition affecting glomeruli, often triggered by immune responses where antibodies or immune complexes damage the glomerular filtration barrier, such as IgA nephropathy, lupus, or post-strep infection. And then there's post-renal, and that is obstruction after the kidneys. So you have blocks in the outflow of urine that cause a back pressure on the renal pelvis and the tubules, impeding glomerular filtration, and can then cause direct damage to the kidneys, kidney parenchyma if prolonged. And that's from kidney stones, blood clots, tumors to the ureteral obstruction, or a bladder outlet obstruction like an enlarged prostate, bladder stones, bladder tumors, neurogenic bladder, and urethral strictures. And since it's like 20 till and leaves us no time for chatting, I'm just going to quickly go over these next ones. So I went into a little more detail about hormonal regulation of the kidneys, since I saw there are a lot of questions that I felt like the format didn't completely cover. So I hope you'll read through these and kind of add some notes for some study. It goes into better detail about the hormone functions like the RAS system. So it's somewhat involved there. There is the aldosterone release, antidiuretic hormone release, parathyroid hormone, as well as the active vitamin D, and then erythropoietin as well. So I am going to leave it there for you guys to maybe take with it what you can and study. I think there's going to be a good bit of questions based on this data. Does anybody have anything to add? Any questions? Let me see, there's some questions maybe in the chat.
No questions. Just wanted to say thank you.
Yes. No, I'm so nervous with this. I stutter over my words. I'm like thinking to myself, oh, you guys are going to hate this. But again, these were so one of our friends took the Anna, the one that it's like $260 for it. So she helped us with getting this data together to help us all succeed. So, we'll just keep at it. keep studying. If there's anything else, Christina, you and I were talking about next week and what we had planned with the speaker.
Mm-hmm. Yes. So next week we have Elena. She is going to present on plasmapheresis and water. So we'll have a speaker next week. Again, if you all want these slides, please send me your email address in the chat so I can send this to you personally after the meeting. Venetia, can you send the slides to me so I can do that? Thank you. Um, Again, just to remind everybody, we are having a NNCC lady coming to present to us on the 27th of August. So if you have any questions for the test and you can't make it, or any questions about the application, please send those to me so I can ask those for you. It will be recorded as well, so we can go, so you guys will be able to go back and review it. But if you have any questions before that, just let me know. We've already started a list. So I would, if you know anybody that wants to take the test and they have questions about the application, tell them to reach out to me, or put it on the WhatsApp or, the Anna community forum, anyway. Um, so many ways to get a hold of us. Venetia will continue putting on questions on the WhatsApp, and we'll continue to be here to support you guys. If you want more a certain subject you want more, clarification on or something, let us know. We'd be more than glad to put a PowerPoint together. I have a pharmacist coming to talk to us. I'm not sure when yet. I have a pediatrician coming to talk to us. I'm not sure yet when. But next month we're pretty full with speakers for every Wednesday except for one. And then in September, we already have the first 2 Wednesdays covered with speakers. So this is for all of us to learn to help each other pass this test. So the more you guys input and let us know what you want in order to pass this test, please reach out. I know it says CNN certification, but these also cover CDN certification as well. Maybe a little more in depth than what you need for the CDN, but knowledge is power. So, but if you guys don't have any more questions for Venetia or for myself, um, it's almost 7:43. We will close for the night. I will put this recording on again in the Anna community forum. And I have everyone's email that put it in the chat, so I will get those slides to you guys as soon as the meeting's over. But does anyone have any questions, comments, jokes, whatever you got?
So, am I able to send this to? I can send this to the members, but can non-members attend the Zoom as well?
Absolutely. Absolutely. And non-members can take the test. They do not have to be an ANA member to take the test. It just saves them a
Okay.
little bit of money. But please share with whoever wants to be part of it. You don't have to
Okay.
specifically be an ANA member. What I do with this meeting, I share it with my acute team and my home dialysis team at work. So anybody that,
Mhm.
is not an ANA member, they have the video and the slides if they want them. So yes, please share. The more the merrier.
Okay. All right. Thank you.
Yeah. Anybody else?
You all have a good night. Thank you so much.
You're very welcome. Thank you all for joining. We appreciate everyone that takes time to come. We know it's with life, it's hard, but thank you. And that's why I record it because, not everybody can be able to attend. So thank you, everyone. Have a wonderful evening, and we'll see you next week. Thank you, Venetia, for a wonderful presentation. We appreciate you.
No problem.
Good
Thanks.
night. Thank you.
Bye.
Bye.